Good afternoon, everyone. So I'll be talking about critical appraisal of a screening test. So as Sir mentioned, there is no critical appraisal guideline for a screening test as such. So I'll be going through a CAS critical appraisal guidelines for a diagnostic test, and later on I'll be talking about the guidelines which you can apply for a screening test as such. So going to a clinical case scenario, a 55-year-old gentleman comes for general checkup, and a routine evaluation, he was noted to have microcytic anemia. So for further evaluation of anemia, a stool for occult blood was done, which came out to be negative. However, he was advised to undergo a scopy in view of anemia for further workup, but he was reluctant to undergo a scopy, and he asked, is there any other test which he can do before deciding to undergo scopies? So in relation to this clinical scenario, I looked up for various studies was done topics on what all tests can be done to detect whether the patient should undergo scopies. I found out this study. This is a multi-target fecal immunochemical test for improving stool-based colorectal cancer screening programs. This is a Dutch population-based payer design intervention study. So I'll be using CAS critical appraisal guidelines for a diagnostic test to appraise this study. So the first question, was there a clear question for the study to address? So going to the PICOT statement, the population which they took were people of 55 to 75 years of age, the people who actually belong to the Dutch National Colorectal Cancer Screening Program. So every year this included around 23 lakh people. And intervention which they used was the test, which is either a multi-target fecal immunohistochemical test, which included hemoglobin, calprotectin, and serpin-F2 detection in the stool, versus a fecal immunohistochemical test, which was already used as a screening test in the Dutch population. So they compared whether multi-target fit was better compared to the normal fecal immunohistochemical test which they used. The outcome which they looked at was the detection rate of multi-target fit versus fit for advanced neoplasia.
So the gold standard was
yes,
colonoscopy biopsy.
Colonoscopy biopsy they had used as gold standard. So the timing, there was no follow-up period for the patients because the test was done as they invited people to do the multi-target fit or fit, and those patients who had positive for that underwent a colonoscopy and biopsy. So this was done at a particular period of time, however there was no follow-up of patients later on. And the setting was Dutch population, and the study design was a prospective population-based intervention study. So they had excluded a few patients. The patients included patients who had previous treatment for colorectal cancer. So probably because these patients would have a false positive detection rate for fit, that's why probably they had excluded. And patients were already done colonoscopy for other GI diseases, so they would have already picked up of those diseases which should have been there by colonoscopy, so they excluded those patients. And patients who had presented with symptoms related to colorectal cancer, so they actually taken all the healthy patients belong to this age group. They did not take took patients who had presented with symptoms, and also patients who had hereditary colorectal cancer. So if there is a family history of colorectal cancer, they already had a higher risk of developing colorectal cancer. So then these tests, they would anyway recommend colonoscopy to detect colorectal cancer in those patients. So using this test won't be much of a significant. That's why they excluded probably these 4 set of patients. So was there a comparison with an appropriate reference standard? So the reference standard which they used was colonoscopy and biopsy, which was a reference standard to detect colorectal malignancies or advanced neoplasia, and it was appropriate for detecting advanced neoplasia. So advanced neoplasia they defined as either patients having colorectal malignancy, having an advanced adenoma or an advanced serrated polyp. So these group of patients were considered under having an advanced neoplasia after colonoscopy and biopsy. So did all the patients get the diagnostic test and the reference standard? So this was not done because what they had done is they had invited individuals of the Dutch population of 55 to 75 years to undergo either a fit or a multi-target fit, and patients who were positive for fit or MFIT underwent a colonoscopy. So patients who were actually negative for MFIT or FIT did not undergo the colonoscopy. So patients who were actually negative did not undergo colonoscopy. So those patients are actually did not undergo a gold standard test. So this is the consort diagram in which initially they had found out around 35,786 participants, out of which they invited all the patients and they advised them to send their stool samples for fit and multi-target fit. And 13,463 patients had sent both fit and MFit tubes to the laboratory, out of which they had valid result for 30,187 patients. Out of which, so 13,187 had valid results, out of which 1,404 had a positive fit or MFit or both. And out of that, so these set of patients who had a positive fit, MFit or both underwent colonoscopy later. So, but even from then, around 134 patients had incomplete colonoscopy data and they had not taken those patients, and only 1,270 participants had a complete colonoscopy data available. So the final analysis was actually done based on these patients, 1,270 patients. So this is one drawback because they did not do the reference standard in all patients. But the problem is all of the patients are healthy patients. So all healthy patients, if you would advise to undergo colonoscopy, they might not be willing for that. So it was practically difficult in undergoing the doing the reference standard in all set of patients. So could the results of the tests be influenced by the results of the reference standard? So this that is no, because so what happens is when the results of the reference standard is known to the patient, people who are doing the fit or unfit, they might have a bias of maybe reporting it wrongly, saying that unfit or fit is positive. But the colonoscopy and biopsy is actually done only after the unfit or fit test was positive. So the reference standard definitely did not affect the screening test as such. And even the participants and the healthcare providers who did the testing for fit and MFit were masked to the results of both fit and MFit. However, the outcome adjudicator blinding was not mentioned. However, when you think about this study, the outcome was actually colonoscopy and biopsy detecting advanced neoplasia. So, inter-observer bias between pathologists based on a screening test is less likely because it's probably a definitive finding that you would find in a biopsy that you would see. So, is the disease status of the tested population clearly described? So, as I mentioned, they have taken all the healthy population in the eligible age group, that's 55 to 75 years, in the Dutch National Fit-Based Screening Program. So, all the patients are healthy, so the disease status of the population was not clearly described. So, none of them had any presenting complaints, and they had actually also not mentioned the baseline comorbidity status of the patients also. And a few things which would affect them to develop a colorectal advanced neoplasia later would be the type of diet they consume, their percentage of ethanol consumers, percentage of smokers. All these would influence the amount of people who are developing an advanced neoplasia later. But the status of the patients is also not mentioned in their baseline comorbidities table. So this is the baseline characteristic table which they had put. So it has only, male and female ratio is similar, and considering the age group, most of the patients belong to the 70 to 74 age group, which was around 25.2% of participants. And then they had taken the number of previous fits which was done in those patients. So they had compared only those things. So they had actually not included their baseline comorbidity status and type of diet consumed and all that. So probably the whole spectrum of patients. So if we think about people who are coming with a presenting complaint, whether they are a mild disease or a severe disease, when they were to take the entire population, probably the whole spectrum of patients is included. There was no spectrum bias in the selection of the patients, probably.
There's only one important point I ever to see when doing diagnostic study. They invited people to take part. Only some people agreed. At least age, gender-wise, was the percentage of males the same in those who were sent the invitation and those who agreed to take part? So males, overall among those they emailed, 50% were males. Among those positive tests, 56%, roughly same. Yeah. And among those who had colonoscopy, 56. So we hope that though many people refused to take part, and then after the first test said, I don't want colonoscopy, many people dropped out. We don't know what happened. Like maybe those who are slightly different people from those who stayed on in the study. That's a major problem in all studies, selection bias. The people who refuse to take part, are they slightly different from those who agree to take part? At least from the gender wise it seems. What about age distribution, roughly similar?
Yes sir, the less than 55 is less, but after that
across the three groups roughly similar.
Yes sir.
It doesn't seem to be. It's not that suddenly the number with colonoscopy were mostly young, whereas overall it was mostly old. It's not like that. So we have to sort of generally think, okay, this results applies to the whole population. Even though many people refused, those who stayed on seem to be similar to those who was the original group. So that's one important thing.
So, were the methods of performing the test described in sufficient detail? Yes, a protocol was actually followed for testing. So, like I mentioned, there was an invitation to participate in the study, which included a participant information sheet and informed consent. So, people who had consented, they were sent 2 tubes to collect the stool samples. And for the MFIT and FIT testing, they had collected stool samples from the same stool sample. And then the testing was done, and patients with valid FIT and MFIT results were selected, and patients with positive FIT and MFIT underwent the colonoscopy and biopsy. So the FIT cutoff which they had taken was 47 microgram per gram, which was the screening cutoff which was followed in the Dutch population at that point of time. So for the MFIT testing, this is how they did the multi-target FIT. So initially they had a hemoglobin testing in the feces. The cutoff was 20 microgram per gram of feces. And if that was positive, that was considered as a multi-target FIT positive. Later on, if that was negative and the hemoglobin level was less than 1.27, that was considered a negative test. Somebody who had a hemoglobin level between 1.27 to 20 underwent the calprotectin testing. So based on that, whether the testing was more than 59.5, it was told as a negative test. But it was not there, then they did the SERPIN F2 testing. Based on that levels, if it's less, then they are considered as a negative test, and if the levels is more than 0.0275, it was considered as a positive test. So this is how they had done the protocol for testing for a multi-target FIT. So they had a clear-cut protocol for testing for both the testing. So what are the results? So before going into the results, few things to consider is, one is they did not do a reference standard for all the patients, that is FIT negative or multi-FIT negative patients, they did not do a reference standard. And by doing that, they are actually assumed that colonoscopy is probably negative for all those tested negative patients. They said probably 100% sensitive to pick up all the cases by a FIT and a multi-FIT, they had assumed. And also in the results also they had actually mentioned the detection rates rather than sensitivity, specificity or likelihood ratios for the testing. So how they define a detection rate was, it was calculated as a percentage of participants with a given lesion type. So this is based on the biopsy, gold standard positive, among those with the valid test results, which is around 13,187 patients. And even detection rate, they also mentioned based on positivity rates of FIT. So what they generally followed in the screening was a 47 microgram per gram cutoff of fecal immunohistochemical test. So based on that, based on the study they had done, they had unequal positivity rates for multi-target FIT and FIT. So when they increased the cutoff, the cutoff levels was decreased, probably a increased number of patients they would have detected based on a FIT. So they had used high positivity rates of FIT with the 9.6 microgram per gram, and also they had used a low positivity rates of FIT, which was based on a 47 microgram per gram. And the unequal positivity was the actual rates which they had observed in the study. So this is what I had explained. So 3 scenarios they had taken based on unequal positivity, equal positivity and equally high positivity. So one thing to consider is, in the scenario 1, the data which they had taken was from the current study itself. That is, the FIT data source was also from the present study, and even the multi-FIT data was from the present study. And the cutoff positivity rate was different for both MFIT and FIT. This is 47 microgram, then positivity detection rate was 4.1%, and the MFIT positivity rate was 9.1. However, in the scenario 2, they had adjusted the multi-FIT results based on the FIT cutoff, and then they had taken the data based on that. So the positivity rate was similar for both. They had adjusted the multi-target FIT detection rate with the FIT, and then they had calculated. And then the scenario 3, actually, when they had actually asked the Dutch government, they did not agree to lower the cutoff for the FIT for detection in this current study, because what they had followed as a screening test was based on the 47 microgram per gram. So based on the previous studies which was done for FIT, they had imputed data, and based on that they had compared for a high positivity rate. So this data for the FIT was actually not from the current study, it was taken from a previous studies which was done with a lower cutoff for FIT. So the positivity rate they had calculated as a percentage of participants with a positive test, which is test positive among those with a valid test result. So total number of patients with a valid test result was 13,187 and number of patients with a positive test result either fit or unfit was 1,404. Number of individuals with colonoscopy report was 1,270 and remaining patients was around 11,970. So like I mentioned, they assumed probably they had a negative colonoscopy result. So going to the result, so this is the scenario 1 which they have taken, in which they had unequal positive detection rate for fit and unfit. So as I had mentioned before, they had not mentioned the sensitivity or specificity for the test, they had mentioned as a detection rate. So going to the detection rate in this, the fit had a detection rate of 1.21 percentage compared to multi-target fit which had a detection rate of 2.27 percentage. But the relative detection rate they calculated as 1.88 based on this data, but they had not mentioned the confidence interval. So compared to this, yes, definitely there is a higher detection rate for multi-target fit, but they had not mentioned the confidence interval in this. So we can't really say how the value is up to what lower level it can go and up to what higher level it can go, and it's not very sure about the results. And this is the scenario 1 when they calculated the unequal positivity rate. So this is the second scenario in which they calculated the equally low positivity rate, which is 3.6% for both. In that also they had got a detection rate of 1.2 percentage in the fit and 1.36, which is slightly higher with a relative detection rate of 1.12. But however, the confidence interval is on both sides of the null point, which is 0.99 to 1.27. So it is probably not significant. So and here they mentioned the confidence interval, and in the next one, which I said that the data was actually taken from imputed from a previous study, they had calculated, but even though they had 1.6% detection rate in fit and multi-target fit was 1.85, still there was no confidence interval because the data was taken from a previous study. So that is also probably not significant. We can't take that into consideration. So I tried to plot a 2x2 table, but it's difficult because they had not. So when we take the gold standard test which is done, which is colonoscopy and biopsy, and the test which they consider as either multi-target fit or a fit. So we have the data for multi-target fit positive patients, which is 299, out of which those patients are colonoscopy also positive. And colonoscopy negative patients, around 902 patients had multi-target fit positive. But this data we don't have because they did not do colonoscopy in patients who had negative multi-target fit, and also even fit also they did not have a data for patients who had negative results for fit. So we really can't calculate the sensitivity and specificity based on the results.
Can we calculate positive predictive value?
Yes, sir. Positive predictive value we can calculate. 299 by 1201 will be
roughly about 30%. And the other one?
159 by 538 will be around 25. 22.
30%. No. Roughly, okay. That's the only thing we can do. Because we can't do vertically with the sensitivity and specificity. Because we don't have the total colonoscopy positive negative. But we can do positive predictive value, which is among those who are positive, 1,201, 299 were positive. And here among the 538, 159 are positive. So we can calculate the two positive predictive values and say, because nobody is left with a positive test. What percentage of the positive test actually lands up with disease? That is a positive predictive value. And we can calculate. Okay, go on.
So how sure are we about the results and consequences and cost of alternatives performed or not? So they have not mentioned the sensitivity, specificity and the likelihood ratio, and as I mentioned, the confidence interval for the relative detection rate in the second scenario was also not mentioned. So the surety of the results is questionable. However, considering the consequences and cost of alternatives, so they had actually done a micro simulation modeling. So which means they had, based on the test results which they had got, they had put probabilities for these individuals to be followed up in future, and what would be their incidence in having a colorectal cancer, and also their mortality. So when they did the simulation modeling, they had said my MFIT would actually reduce the colorectal cancer incidence by 21% and would reduce the mortality by 18% compared to a fit-based screening. This is what they had mentioned, but how they had arrived at this, they had not mentioned in the study. And also regarding the cost effectiveness, also they had said based on these microsimulation modeling results, if they had scored around 106 patients, one mortality they would have prevented with 148 euro for one multi-target fit, which they had said is cost effective for their country. So, and can the results be applied to my population or patients of interest? So the results cannot be applied is what I felt, because India has actually a lower incidence rate of colorectal cancer compared to the Dutch population. And the baseline characteristics of the study population, that is the Dutch population, is not mentioned. So we don't know whether it is how much is them different from Indian population regarding their diet, comorbidity status and all that. And the study results are also not mentioned in terms of sensitivity or specificity or likelihood ratio for it to be applied to another population. So the results probably cannot be applied to my population of interest. So like this is a global incidence rates of colorectal malignancy. So just to want to highlight two areas. This is where the Netherlands will come the Dutch population, and this is what India's is. So with the higher darker shade, it would mean more than equal to 21.9% incidence compared to Indian population, which had a probably 5 to 6% incidence. So it would,
per 1,000,
per 1 lakh population. So per 1 lakh population, so the incidence is significantly lower in Indian population. So we would need a population-based studies before considering this. And can the test be applied to your population of person of interest? Yes, test can be applied because it's a simple test considering good detection rate, which I mentioned, and also can be easily done and results can be interpreted. And based on the studies, like they had used a fit cutoff of 47 microgram, it had a sensitivity of 37.3% based on the previous studies. And also the cutoff is increased, reduced to 10 microgram, sensitivity increases to 92.1% with a specificity of 85.8%. Even multi-target fit, based on the previous studies which they had done in their population, it had a sensitivity of 42.9% and a specificity of 96.6%. So, based on this, we can maybe consider using the test in our population. However, based on the study, the results probably cannot be applied to our population. Were all outcomes important to the individual or the population considered in the current study? Probably yes, because they had not followed up the patient, but still they had used some microsimulation modeling to look at the long-term outcomes in terms of incidence of colorectal cancer and mortality, which showed a significant results according to them. So they had taken almost all the outcomes which are important for the individual or the population. So what would be the impact of using this test on your patients or population? So as I had mentioned, Indian incidence for colorectal cancer is low compared to the studies in India. But currently widely used test is a stool occult blood test, which has got a sensitivity range of around 30 to 70%. If you do a single test of stool occult blood, the sensitivity will be low. If you do 3 tests, the sensitivity will be higher. But still has got a higher false positive detection rate. So according to the data, fecal immunohistochemical test is actually available in India and has got a higher sensitivity up to 92% if a lower cutoff is used. But MFIT it's not available in India currently. So FIT can be used as a in a specified set of people in a case by case basis, based on the finances and the availability of the test. Because stool occult blood testing cost for one stool occult blood testing is around 250 rupees compared to fecal immunohistochemical testing, which is around 1270 rupees. So a single test would be around 1270, but we would still need more studies in the Indian population to maybe decide on use. But still we can use it in a case by case basis. But like we say, like the incidence of colorectal cancer is lower, but lung, breast, and genitourinary and oral cavity malignancies have higher incidence in the Indian population. So probably we need more screening programs for the same, those malignancies before going into the colorectal malignancies for screening programs. So this was the diagnosis.
Before that, I'll just take 1 second. Just go to the next slide. We've got some space. So I'll just show this. Sit, 1 minute. Suppose we do a diagnostic test. The colonoscopy should be there for everybody. And then you have a biopsy positive or the colonoscopy positive, negative, and the FIT or the MFIT positive, negative. What they have done is they've done a FIT test first for everybody. If the FIT test was positive in colonoscopy, so you have a FIT positive and then you have a FIT negative. Now the problem why they didn't do colonoscopy, first it's expensive, it is invasive, and people have to come to a center to do it. So they didn't complete the full diagnostic study. So suppose you are doing a small study in a small center. It's very expensive. How can we do? This becomes a big problem doing colonoscopy in this population. Either you can simulate and say what these numbers should have been if the study was done somewhere else, or you can do, let us say that you have a 1 lakh population, okay? Just for numbers sake. What number you think will have colon cancer? What's your guess? Oh, yes.
10%.
10% of Indian people means 1,000 people.
For 1 lakh.
10 per 1 lakh. So 10. So what number will be here? Correct, no? So imagine you're going to do colonoscopy on all people, most of whom won't have. So one of the options is to randomly choose a group of people and do the colonoscopy on them. Let us say you get the total number positive here to be 10 on 10, and among these you get 2 here. Then you can randomly say that among these negative people, I'll randomly do on about 100 people. So because I'm randomly choosing from all the negative, it still reflects all the negative, but I get a series of numbers here which will reflect ultimately the larger population. I know it's a problem. I should actually have done this colonoscopy on all this 99,910 negative people, but I don't have the money or the patients are not willing. But to overcome this problem, I'll do this way. Another way that people do is you take only people who are colon cancer positive and negative already diagnosed by colonoscopy, and then you do the test fit positive and fit negative, and then you'll get an easy 2x2 table. This is called case control study, retrospective study, but it doesn't reflect the actual population of this large group. This will give you a higher sensitivity and specificity. So it's difficult in a screening situation in a large population till 1 lakh people come and have colonoscopy. So they have done with this kind of method. Okay, go on.
So now I will go on to the guidelines. So what I have done now is a critical appraisal of a diagnostic test. So I try to do the appraisal based on a diagnosis for a screening test actually. So there are various guidelines for a population-based screening program. So there are UK-based guidelines or also WHO-based guidelines. So I will be going in detail on one of the UK-based guidelines, and it is not actually an appraisal tool but guidelines before you implement a diagnostic test as a screening test in the population. So they've specified set of questions. So one is about the condition. So is the condition a major health problem before implementing? So consider in this case, colorectal cancer is a leading cause of malignancy worldwide, third most common cancer, and the second leading cause of cancer-related death worldwide. But if you take for a country like India, India has got a lower incidence compared to the Dutch population. Second thing is whether the epidemiology, incidence, and natural history of the disease is known. So for colorectal cancer, these things are well known and studied in detail also. There's higher incidence in countries like Australia, New Zealand, Europe, and lower incidence in Asian countries. And whether the association between the risk or disease marker and serious treatable disease is also there. So there is an association between the risk and the disease, and after the disease occurs, there is a serious treatable disease. So we know about the risk factors of colorectal cancer. There are hereditary cancer syndromes, ethanol, processed meat, tobacco, inflammatory bowel disease are conditions which would predispose them to develop later on cancer in their lifetime, and also disease is treatable if it is identified as an early stage. So there is a serious treatable disease, and whether all the cost-effective primary intervention prevention interventions are implemented before you consider going to a screening program. So the primary prevention intervention for a colorectal cancer would be regular physical activity, consumption of adequate fruits and vegetables, avoiding ethanol intake, tobacco cessation. So all these primary prevention interventions should be implemented in detail before you go ahead with the screening program. And the next question is if the carriers of a mutation are identified as a screening test. So the psychological implication of screening, whether it is being thought of not. So for example, people with a carrier mutation should be counseled regarding the risk of developing a disease if they have the carrier mutation, as well as what would you do after you detect a carrier mutation, whether there would be periodic screening or genetic counseling. So all the concerns and doubts should be addressed before going ahead with a screening program involving a carrier mutation. So the next thing is about the screening test assets. So whether the test is simple, safe, precise, and validated. So in this current scenario, the fit and unfit test is simple and safe. It is one test which can be done at the home itself. You just need to collect a stool sample. And based on the previous studies which has been done, it is a validated test and is also precise. And we know the sensitivity and specificity of the test, so it's probably a good test. And whether the distribution of the test values in the target population and a suitable agreed cutoff level is there or not. So this varies. Like if we had done the test in the Dutch population compared to we had done the test in the Indian population, the distribution of the test values will be definitely different. So they had used a cutoff level of 47 microgram per gram in their Dutch population. Probably in the Indian population it might be different. So we need to go ahead with a suitable cutoff to have a agreed cutoff level should be there. And regarding the test, whether the test is acceptable to the target population from sample collection to the delivery of the results. So every test before implementing as a screening test, it should be culturally acceptable to all the population in that particular country or population. So fit or unfit testing, it's just involve collection of stool sample. So that should be acceptable only. And there's an agreed policy on further diagnostic evaluation and choices for individuals with a positive test. So once a screening test is positive, what would be the further diagnostic evaluation? Whether it's a protocol laid on for that, that should be there before implementing a screening program. So considering this scenario, there is we have colonoscopy and biopsy for confirmation of the test, and what are the choices, other choices for individuals to do when there is a testing which is done. So that also should be there. And for the intervention, so whether there is effective intervention for the people identified through screening, and intervention at a pre-symptomatic phase leads to better outcomes for the screened individual. So this is what Sir had mentioned at the beginning, that whether there is, for once you select a screening test for a disease, after you screen the patients and you identify the patients with that particular disease, there should be effective intervention for those people. And also the intervention should be, so at a pre-symptomatic phase, if you intervene, there should be better outcomes for that screened individual. So for example, with patients who had FIT positive and they did the colonoscopy and found out a polyp which has got a higher risk for malignancy later, then they can be serially followed up periodically to look for any changes, or they can intervene at an earlier stage by doing a surgical excision of the polyp. So that means early diagnosis and treatment of the precursor lesions would probably lead to a better outcomes in that patient. And whether it's agreed evidence-based policies covering which individual should be offered interventions and what. So as in, so after you perform a test, which individual, so if you are identified patients, one patient having a normal polyp, one patient having an advanced polyp, one patient having a colorectal malignancy. So what are the evidence-based policies for different groups of individuals to undergo what in the future? So whether there is different management strategies and surveillance strategies based on the risk and the stage of identified lesion should be there before implementing a screening program. And for the screening program as such, whether there is evidence from high quality randomized control trials that the screening program reduces the morbidity and mortality. So for the FIT as such and unfit, there are multiple RCTs which is done in the Dutch population and looked at the reduction of morbidity and mortality for colorectal malignancies. And the current study also used the micro simulation modeling, which showed there is reduced incidence and mortality when they followed up those patients in the simulation modeling. And whether the information about the test and the outcome is readily understood by the individual screen. So a proper information sheet has to be provided to the person who is undergoing a screening test about the test as well as the outcome and what can be done if you have a positive test. And whether the screening program is clinically, socially and ethically acceptable to the health officials and public. So when you implement a screening program in a country, it should be acceptable to all, like all the healthcare staff or the primary people involved in probably implementing the study. So it should not expose them, the healthcare staff, to risk while performing the screening, and it should be acceptable to the public also. And whether the benefits outweigh the potential harm. So the benefits of implementing a screening test would be there will be reduced severity, including less invasive treatment. There will be reduced incidence of the disease once you implement a screening test, or there will be reduced mortality after implementing screening test. What are the probable harms which can occur? There might be overdiagnosis of cases. There will be false negative, false positive, and diverting the health resources for a screening test, which would probably take the money which is being used for something else. So whether that would have a higher benefit compared to harm. that you need to look at before implementing a screening test. And the cost effectiveness of the screening program, so it depends on the number of people needed to screen to prevent one death versus the cost of treatment of a patient who develops a colorectal malignancy. So whether the screening program is better in terms of screening the patients and identifying them early and treating, or the cost of treatment is lesser or higher. So based on those two, you need to decide whether the cost effectiveness of the screening program is good or not. And implementation criteria, so before implementing, the clinical management of the condition and the patient outcomes should be optimized prior to starting the screening program. So what it means is like the management of the condition should not be different in different settings. There should be a standardized management protocol all over the country, and you need to strengthen the health infrastructure before implementing screening program. So it shouldn't be like at a particular place the test is done and the patient has been offered something else, and another place, another center, the patient is offered something else. That should be standardized across all over the country. And all other options for managing the condition are considered, and no more cost-effective intervention could be introduced with the resources available. So this would mean the screening programs you are implementing, it should be cost-effective compared to all the other treatment and intervention available if the patient has been detected with the disease. So the cost-effectiveness of the screening program should be better compared to the treatment intervention. So then only we should implement such a program. And plan for managing and monitoring the screening program. So before implementing the screening program, there should be laid guidelines on what are the quality and reference standards to be maintained, what is the periodic surveillance which they are planning for. All those things to be maintained before implementing a screening program, and adequate staffing and facilities has to be there before implementing a screening program. And whether there is evidence-based information about the purpose, consequences of screening and preventive treatment intervention to be made available to the participants. So like this is something which is previously also mentioned, there should be details about the natural history of disease, what are the benefits of early screening, and what are the treatment options available. All these to be made available to the participants before they undergo screening. And anticipate public pressure about the eligibility criteria, screening interval, and scientific justifications to the public. So this would mean what, who will be screened, which individuals will be screened, as in which age group people are going to undergo screening, and if negative, what will be the time intervals for screening, like later on. So in 1 year they have done a screening, whether they later on there is no screening or not, or whether they will do screening every 3 years, every 5 years. That should be mentioned, and there should be scientific justifications to your screening eligibility criteria and intervals. So these are the UK-based guidelines. So this is the Wilson and Juckner's principles of screening, which is mentioned in the WHO guidelines. So this also talks about almost similar things, like the condition should be an important health problem. There should be an accepted treatment for patients with recognized disease. There should be facilities for diagnosis and treatment should be available. And there should be a recognizable latent or early symptomatic phase for screening. And there should be a suitable test or examination. And the test should be acceptable to the population. Natural history should be known. And there should be agreed policy on whom to treat as patients. And the cost effectiveness should be taken into consideration. The case finding should be a continuous process and not a once and all project. So this is the WHO guidelines which I mentioned for a guidelines for a screening program. So coming to my case scenario, so the fit-based screening, whether I would suggest, so multi-target fit is not available in India right now. However, I would definitely suggest fit-based screening for the patient, as it is available in India and has better sensitivity to pick up cases with advanced neoplasia. However, based on the current study, I would not recommend it to be used as a screening program in India because few things are, one is there is lower incidence of colorectal cancer in India and we need more studies in the Indian population. And also, like I mentioned in the guidelines for the screening program, implementing primary prevention strategies for colorectal cancer should be there first prior to implementing a screening program. And there should be standardized treatment strategies all over India, which is probably not there currently in India. And also the cost effectiveness of the program in the Indian population also need to be tested before implementing a screening program like this in Indian population.
Thank you. Let's give him a hand.